Welcome to the PODdoctors. I'm Dr. Damien Dauphinee, and I'm here with my partner,
Dr. Raafae Hussain.
And welcome to Season 5. We have been on sort of an extended hiatus because Dr. Hussain had to study for his boards.
Yep.
And so we haven't really put out any new material for a while. So we are getting ready to crank away.
Back and hungry.
Yes, back and hungry. And actually, we have lots of good questions from some of our subscribers. So we're going to try to answer some of those. Some of them are going to be based on old shows that maybe we didn't identify certain questions that patients and some of our subscribers were having based on what we talked about during that particular episode. So we got some bunion questions. We got some questions about skin lesions. We might delve back into fungal infections again, talk a little bit more about how we're approaching toenail fungus and how we're diagnosing it, because we've got a pathology lab now.
So much more successful than just blindly guessing.
Yeah, absolutely. Yeah.
I had a patient today. I don't know if I told you this. I had a patient today coming from Mississippi for an ankle replacement. He saw our podcast on YouTube. And
nice. MI-Sciences IPPI. There you go. Yeah. Mississippi. Well, yeah, and certainly that's a subject that we probably need to spend a little more time on, because it's really evolved in the last 25 years. Ankle arthrodesis was the gold standard when I started practice.
Yeah. Because
the implants weren't terrific. The longevity wasn't terrific. So that's really changed, and it's flip-flopped. And so now we're doing way more implants than we are fusing of ankle joints, which is, I think, great in the long run.
Huge paradigm shift, I think.
It really has been. So today, we wanted to touch base on something that kept popping up during the really cold February. It's now April 1st as of today. Happy April Fool's Day to everybody. But we had a series of patients come in during February here in Dallas, where we had a snap of really cold weather. And there are still parts of the country that are still experiencing cold weather. So we wanted to talk a little bit about something called chilblains.
Yeah, chilblains or Pernio or Pernio chilblains or whatever you want to call it. So
it's interesting, patients will come in with this weird description of, I get these little red patches, they're itchy, I have pain, what the heck's going on? And the funny thing is it kind of happens sometimes several weeks after a cold weekend or 3 or 4 days of cold weather here in Dallas. And so they don't attach the skin changes with the cold weather that happened 10 days ago.
Yeah.
And it's a phenomenon that I don't think I've seen more than I saw this year, which was kind of weird.
Honestly, we talked about this. There's been an uptick, I think, and I couldn't tell you what the reason is. I'm no epidemiologist or whatever, but there's definitely an increased number of chilblains patients I've seen this year. And I mean, when I say increase, it's probably like 3 or 4 I've seen this year. It's not a lot, but in the last couple of years, I'd see like maybe 1 a year, if that, But for whatever reason, this last, 2-3 months, we've seen a couple back to back to back. And we're like, look, people are probably going through this, especially here in Texas, where we don't really get too much cold weather. I'm sure more in the northern states. So we thought we'd dive into it and see what it is.
And I think that picture in the middle is representative of some of the cases that we see where it's very subtle. The one on the left, that's pretty obvious. That clearly looks like a contact injury, cold weather being the number one thing I would think of if it wasn't a diabetic who had peripheral arterial disease. And the people that were coming in with this, a couple of them had a history of Raynaud's, which I think is another contributing factor.
Yeah.
But most of them were healthy. And there you go. Upper left hand looks fairly benign. Maybe they wore some bad shoes. And you're thinking, well, what could it be? But if you're wearing tight shoes with weather that's in the 30s and 40s, it doesn't have to be frigid.
Yeah, they don't have to freeze over.
Yeah, and if they were working out in the yard in a 40-degree weather day and their feet got wet, the exposure to damp conditions, cold wind, and then I think that having low body weight, most of the cases that I saw in February were women who were slender. They weren't wearing appropriate socks when it got cold. They were wearing regular, really thin socks. They may have been
Hey Dudes in the wintertime.
Don't get me started about Hey Dudes. No offense to the Hey Dudes manufacturers, but y'all are keeping us in business.
Yeah.
So, goodness.
But all the patients I saw were female.
Yeah.
all came in with very similar looking spots like this. They'd complain of tenderness. They'd complain of itchiness.
Yeah, the itchiness is
Yeah.
a big part of it.
Dry, scaly skin around that area. So I'm initially thinking, oh, it's probably athlete's foot, right? I go in, do my exam. I'm like, this doesn't look like your normal athlete's foot. This looks a little bit different.
And when you touch them, it's tender.
Yeah, super
if you
tender.
Catch it at the right time.
Yeah.
Yeah.
So what's the difference between Raynaud's and Chilblains, right? So Raynaud's is an acute injury, right? Acute condition, excuse me, where it'll be.
Raynaud's is a chronic condition.
I mean, when you see the symptoms,
Yeah.
the symptoms will be pinkish, purplish, even white if it gets really bad for that time period when it's cold. But when it goes away, you put them in warm water, an hour or two later, it goes back to normal. And they don't have this discoloration lasting for excessively long periods of time.
And with Raynaud's, you think of that red, white, and blue disease.
Yep.
So yeah, the toes will turn white. You get a vasospasm. The vasospasm will break. They'll become red and then kind of purplish. And that's really, I think more a genetic preponderance. Yep. So this, I don't know that they know that Chilblains is genetic. I don't know. There may be some predisposing factors that we're not aware of yet. They haven't identified. But Chilblains, between Chilblains and frostbite, the difference really is temperature.
Yep.
So it doesn't require frigid 20 teens Fahrenheit to cause chilblains. It could, like we talked about, it could be in the 40s.
Yeah. Yeah. They don't have to freeze over it. You don't have to be hiking through Mount Everest to get chilblains, which would be more likely.
Cold, damp air. I mean, that's really where you see this.
Yeah.
Genetics. Yeah, there's probably a genetic component to it. Hormonal changes. These are the things they're just theorizing on, because I don't think anybody knows.
Yeah, there's no true reason that they have been able to figure out, but it's definitely some type of injury or some type of genetic injury that had led to this moment in the vessels. They contract, they cut off the blood flow to that area, and that's what causes the tenderness. It's like throwing a rubber band around your finger.
Well, clearly, if you're a smoker, you're probably if you're a slender smoker, you're like almost inviting chilblains.
So treatments. What are our treatments, right? So there's a bunch of simple things you can start with. Thick socks, honestly, super simple.
Well, prevention, sure.
Yeah, prevention.
Yeah.
And then when it does happen, you can put them in your feet in lukewarm water for extended period of time. Not blazing hot, not boiling. We just want them to be lukewarm. And then if you want to get real fancy, if this is a more chronic problem that flares up every couple of months or during the cold weather, this is going to happen. Sometimes your doc might put you on nifedipine or pentoxifil or any of these medications. But I like to start with the simple stuff as topicals. I like to do the topical nitro. I think it works really, really good. It's a vasodilator. You put it on the area that's affected, and hopefully it'll help alleviate some of those symptoms.
If you're catching it right away, I think that works great. If it's like several weeks later, I don't think nitrobid works. I think you're probably better off using the betamethasone or topical steroids.
Topical steroids.
Yeah.
I also saw in a couple articles that they use lidocaine. Lidocaine is a natural vasodilator also.
Yep. Just topical lidocaine gel or patch.
Alleviates the pain because of the lidocaine. Plus it's a vasodilator. Now,
pentoxifylline is unique in that it, essentially what it's doing is it's making the red blood cell more pliable, so it can get through smaller blood vessels. We're using that in a patient right now who has a complication of venous disorder called atrophy blanche. And atrophy blanche is kind of a scarring around venous leg ulcers that can be extremely painful, and that's one of the treatments is pentoxifylline. So again, same reason, you're trying to get red blood cells to fit through tiny blood vessels to try to bring nutrients to the skin where stuff's not getting there.
But aside from these simple measures, there's not too much out there. There's no surgery.
It's self-limiting.
Yeah.
I mean, everybody wants a definitive treatment right off the bat, and so we can do certain things to kind of alleviate some of the symptoms. But this is self-limiting. You're not going to lose your toe over this. It's going to generally get better with time. You wait 2 or 3 weeks and the patients aren't even complaining any longer. So
now I do want to make a point to put this out there for patients who have neuropathy, right, and have these type of problems, don't have the best sensation in that area. Avoid those electric socks and avoid hot foot baths unless you can feel the temperature yourself before
physically take it with a thermometer.
Yeah,
I agree.
We don't want to cause any more problems on top of chilblains. So
I think neuropathic patients, from the standpoint of complete sensory loss, they're at risk for all kinds of things that they don't know are happening. And, clearly they are susceptible to the sort of the silent changes in the peripheral arterial tree that may be happening all over their body, and they're unaware of it because it should be painful and it's not. So they wouldn't notice the itching, they wouldn't notice the pain. They might see the skin lesions.
Yeah.
And that might be the thing that brings them in.
But aside from that, we don't really have too many other, options. Like I said, there's no surgeries for this to get this better.
Nope. Just treat tincture of time, and then try to avoid, when you know you've had it before, you need to avoid cold weather, damp cold weather, unless you are really well insulated.
Yeah.
Absolutely. Well, cool. Well, we got that one out there. Welcome to season 5, and we will keep rolling them out here as often as we can. But keep looking out for us. If you have questions, if you have other suggestions for topics we need to cover, please hit us up on the socials. Thank you.
Bye.